Good evening, friends. This is 45th annual conference of Mumbai Hematology Group. Today is day 4 of the satellite symposia, the main conference being scheduled on coming Saturday and Sunday for the whole days. These events are managed by Mice Ideas flawlessly, and I thank them for the same. Today we have 3 parts of this webinar, and they're supported by 3 industry giants. The first one by Bharat Serums and Vaccines, second one by Zydus, and the third one by Jensen. So we begin with the first part of the webinar, supported by Bharat Serums and Vaccines, and I'm grateful to them for supporting our academic activity. This is a lecture by Dr. Pankaj Malhotra on current concepts in diagnosis and non-transplant treatment of aplastic anemia. Dr. Pankaj Malhotra, MD, FRCP, is Professor and Head Department of Clinical Hematology and Medical Oncology, Postgraduate Institute of Medical Education Research, Chandigarh. Over to Dr. Pankaj Malhotra.
Thank you, sir. And first of all, I would like to actually congratulate you and the Mumbai Hematology Group for organizing these webinars, which are going on continuously for last so many years, I think post-COVID. And, whenever you are free and on Saturday and Sunday, just sit there, there's some webinar which is going on hematology. So it is, so interesting and so good, sir. So I would like to congratulate you on that, on, organizing these webinars without fail. So coming to today's topic, which is current concepts in diagnosis and non-transplant treatment of aplastic anemia. Since it has 2 components, diagnosis and treatment. So we'll first discuss about the diagnosis of aplastic anemia. And we start with a case history of a 24-year-old male who was seen in the outpatient with weakness and fatigability of 3 months duration and gum bleeding of a month. Hemoglobin was found to be 5 gram, and he received 2 units of blood transfusion before coming to us. There was no history of any fever, jaundice, or indigenous drug intake. A CBC which was done showed hemoglobin of 5.6 after 2 units of blood transfusion. White cell counts were 2000 with predominantly lymphocytes and platelet 12,000. And on examination, he had ecchymotic spots over the body, gum bleeding. There was no lymphadenopathy. The chest, CVS, abdomen, CNS examinations were normal. And the clinical impression was, aplastic anemia. So somebody coming with this history, obviously the clinical diagnosis is aplastic anemia, and the bone marrow aspiration and a biopsy was done, which was consistent with aplastic anemia. It was severely hypocellular marrow with cellularity less than 10%. Now, his age is 24 years. So obviously the first step in the outpatient, you will say, okay, advise HLA match, because if there is a sibling match, you would suggest an transplant, or if there is no match, then you suggest a ACE regimen, which is ATG cyclosporin and eltromopeg regimen. But are you happy, satisfied with the examination and treatment approach? Even though, inside your heart, this is aplastic anemia, but is this sufficient, or do you think that there is a lot of progress which has taken place, and do you need to do something else? So what specific history and examination are supposed to be done in a suspected case of idiopathic aplastic anemia, and whether that really matters? Let's see in subsequent slides. So somebody coming with a with pancytopenia, obviously you have a differential diagnosis, and the first thing which should come to your mind is whether this is related to the pancytopenia is related to infections. So obviously you will ask the history of fever and jaundice and many other things, and whether this patient has an exposure to environmental exposure to toxic drugs or other one which can cause pancytopenia and hypocellular marrow, or is it a clonal disorder, or whether it is some inherited bone marrow failure syndrome. And sometimes, rarely, we do see these pancytopenia in pregnancy, which after termination of pregnancy recovers. so which is called pregnancy associated aplastic anemia. So the point which I'm trying to say is that idiopathic aplastic anemia or acquired aplastic anemia is a diagnosis of exclusion. So you have to exclude a lot of other disorders based on the history, examination, and investigations before you make a diagnosis of aplastic anemia. And the reason for that is because ATG is an immunosuppressive drug that will not work in inherited and toxin mediated aplastic anemia. So before you say that the ATG is not working in our patient, that means have you conclusively excluded the other disorders where the ATG is unlikely to work. So the initial evaluation of aplastic anemia is based on the medical and family history, like whether the patient has long-standing cytopenias, macrocytosis, which basically you are trying to rule out whether there is a inherited bone marrow failure syndrome which is happening. Developmental like short stature or physical anomalies, again that suggest Fanconi anemia or diamond blackfen anemia or telomeropathies. Then immunological or infectious diseases, recurrent atypical infections which could suggest GATA2 or other primary immunodeficiencies. Then dermatologic, sometimes you do find gray hair, and especially before 25 years of age, if somebody has gray hair or reticulated skin pigmentation, cafeolate spots, again that suggests short telomerase syndrome. Then pulmonary fibrosis or early onset emphysema, again that suggests either telomeropathies or GATA2. Abdominal like pancreatic insufficiencies, liver fibrosis or renal anomalies. Then neurological ataxia and nystagmus, which again suggests an inherited form of bone marrow failure syndrome. Cardiac anomalies, lymphadenopathy, again suggests either GATA2 or inherited bone marrow failure syndrome. Then oncologic, that means you are asking about the history of cancer, especially squamous cell carcinoma in the head and neck region. Then that basically means that you are asking history from each system. So it's the full examination and full system examination which you need to do based on the history and examination. And coming to the laboratory investigation, which again has in the last few years, there's a lot of development which has taken place before in patients who present with pancytopenia. So obviously the first thing is complete blood count, reticulocyte count, percentage of hemoglobin F, vitamin B12, folate we do, but rarely in an elderly patient or adult patients, copper and zinc levels too are done, which can responsible for pancytopenia like presentation. Then viral hepatitis A, B, C, HIV, we all do that. Rarely we do EBV parvovirus. LDH hepatoglobin suggests a hemolysis component. That means there may be an underlying PNH clone or so. Then ANA or double-stranded DNA suggesting SLE, especially in a young female patient. Immunoglobulin levels, looking at the immunodeficiencies. Flow cytometry for B, T, K, and NK cells, again suggesting either severe or combination of B, T, L, NK cell deficit or GATAs too. Then telomere length assessment, which is, I don't think so it is available routinely at most places. Then chromosomal breakage analysis, which must be done at least less than 40 years of age. Bone marrow aspiration and biopsy, obviously. Conventional karyotyping, HLA typing. Myeloid malignancies gene sequencing, these days it is available. So most of us do get it done, but the significance is unclear and we can have some discussion on that. Then inherited bone marrow gene panel sequencing, because sometimes chromosomal breakage studies, you may not get the exact inference. So you have to do the gene panel sequencing, which is now available routinely. Erythrocyte adenosine deaminase for DADA or diamond blackfen, pancreatic isomylase, fecal elastase. So all these actually you need to do before you say that this patient has acquired aplastic anemia. The other thing you want to know is whether it is severe, very severe, or non-severe aplastic anemia. So the definitions of which, the diagnostic criteria which are depending upon the bone marrow cellularity and the absolute neutrophil count, which is if less than 500, platelet less than 20,000, so severe. But if the neutrophil count is less than 200, then obviously it is very severe aplastic anemia. So the investigations which were done in current patient, the CBC, which already I have shown you, the retic was 0.2, the peripheral blood film shows few macro hypochromia, and this was post-transfusion. MCV was 80. LFT, RFT, and viral markers were all okay. Fasting blood sugar, chest X-ray, ECG, urine examination, PNH workup, and chromosomal breakage studies did not show any breaks. So a diagnosis of acquired severe aplastic anemia was made. So this is how when you have a patient of pancytopenia, so you would like to make a diagnosis, you would like to do these investigations. Obviously, you cannot do all the investigations, but try to do as much as possible, basically to exclude inherited or other causes of aplastic anemia. Now we come to the transplant treatment of aplastic anemia, which basically means the immunosuppressive therapy. The standard and experimental drugs. Standard are ATG, either equine or rabbit, cyclosporin, and thrombopoietin receptor agonist like eltrombopag or romiplostin. Cyclophosphamide is very effective, but now it is kind of an experimental. Mycophenolate, sirolimus, all those you use when the patient has toxicity because of cyclosporin. Alemtuzumab is one which in India, it is available for the neurology patient, but hardly anybody, hardly hematologist uses for aplastic anemia. Fludarabine, declizumab, and most of us actually use danazol, stanozolol, and rarely corticosteroids in patients who are non-affordable, even though corticosteroids are considered as contraindicated to be used in aplastic anemia patients. So for this patient, you have decided to give ATG-based therapy. So the question which you actually ask, what is the type of ATG which you want to use? That means either horse or rabbit. What is the dose of ATG? Whether to add eltrombopag, and if yes, when to add eltrombopag, when to assess the response, and what are the alternative treatment option in case of non-response to immunosuppressive therapy. So first question is horse or rabbit ATG, although this is settled, but for all the residents, we just go back into the history and discuss about why it is why we need to know whether we use horse or rabbit ATG. And we also have a porcine ATG, which in India obviously is not available. So ATG became kind of a treatment for aplastic anemia from 1970s, and this was the publication in New England Journal of Medicine in 1991 when it was compared with cyclosporin or not. And in this series, 84 patients with ATG and methylprednisolone and ATG methylprednisolone and cyclosporin. And at 3 months, there was a significant difference between the response rates in patients who received ATG plus cyclosporin, which was confirmed at 6 months. But since almost since that time only, the rabbit ATG was used for aplastic anemia. And I'm just quoting one paper where 20 patients with severe aplastic anemia were treated with rapid ATG compared to 67 historical control. And at 3, 6, and 12 months, the response rates were similar with rapid ATG versus horse ATG, 40% versus 55% or so. And so you had these kind of trials, multiple trials in the literature where they suggested no, you can use rapid ATG and it is more immunosuppressive, so it's better to use this. Finally, NIH carried out the study comparing horse versus rapid ATG, a randomized control trial, and they recruited patients from 2005 till 2010. And in this, there was a large unexpected difference. Nobody was expecting this much of a difference in response rates of horse ATG versus rabbit ATG, 68% versus 37%. So that's why it is called unexpected difference. And even the overall survival, there was a difference, 96% versus 76% horse versus rabbit ATG respectively. So After the publication of this trial, the horse ATG is the standard of treatment to be given in the first line therapy in acquired aplastic anemia. So these are some of the studies comparing horse and rapid ATG, and some of these are prospective, and there are 2 meta-analyses which clearly shows that the response rates of horse ATGs are better than rabbit ATG. So you are going to use the horse ATG. What about the Indian ATG or thymogam? This is one of the publication which was a multicentric study which was carried out at different centers, and the name of the authors are written on this. So the response rate, this was a prospective study, and response rate in this was around 50%. We have other studies which have used thymogam, and you can see these are mostly retrospective studies where the response rates have been varying from 40 to 65% or so. We also have ATGAM. This was one of our study where we use low dose, and I will discuss a little bit about that. The ATGAMs, again, the response rates are almost the same. So I feel that whether you use Indian thymogam or ATGAM, the response rates are not much difference between the two. So horse ATG is the winner out of that. A little bit about the porcine, which is available in China. So porcine ATG versus rabbit ATG, and the response rates were almost same at 6 months, at 3 months, 6 months, and at 12 months. So if available, if it is available, you can use porcine. So the dose of ATG generally is 40 milligram per kg per day. But we have been using lower dose in many of the patients, and the response rates are almost similar. And why we use a lower dose? Because many of our patients are poor. So instead of not giving any therapy, if you use lower dose and if they get better, this is how we started. And finally, when we did a retrospective analysis, the response rates were quite good. And this is actually based on studies which are there in the literature where they have used lower dose in patients who are older than 60 years. So this is one study. This is another study where this is Australian study looking at the lower dose of ATGAM. The response rates are same. So this is another study. So you can use a lower dose also if you feel that the patient is not affordable for the full dose ATG based therapy. Now, the next is whether to add eltrombopag or when to add eltrombopag. So we all know that eltrombopag initially came for the treatment of ITP. So the treatment was thought to be given in aplastic anemia to stimulate megakaryocytes, and many of these patients are requiring platelet transfusion. So that was the initial thinking. But when they actually started using eltrombopag, they saw there was an improved hematopoiesis, and the dose which was used was much more than what is used in ITP, from 50 milligram to 150 milligram. So this was one of the initial paper which suggested that almost 44% patients who were refractory to multiple lines of therapy had a response at least in one lineage at 12 weeks. So this is how it started coming up, and then other people did this study, and they say the responses are sustained even on discontinuation of therapy also. So obviously, once you have this experience, you would like to use this in a randomized fashion. So this is the NEJM paper published in 2017. From NIH, and there this is a prospective phase 1 to 2 study where they had 3 cohorts. The first cohort received eltrombopag from day 14 to 6 months, to cohort 2 from day 14 to 3 months, and cohort 3 from day 1 to 6 months. This was basically based on, they were not sure whether the patients can develop toxicity if you start from day 1, and whether we really need to give for 6 months or even 3 months is sufficient. And that's why you had all these 3 cohorts. So all the 3 cohorts responded very well, and responses were above 80%, 87%, and 94%. the cohort 3, when they started the eltrombopag from day 1, had the maximum response. And this is the extension of the study, which is published in this year. The long-term outcome, basically, they had an extension cohort. They wanted to see how much clonal evolution is there in these patients. So the overall response rate at 6 months. And what they actually saw was that the relapses occurred at distinct time points after cyclosporine dose reduction or eltrombopag discontinuation at 6 months, and after 2 years when cyclosporine was discontinued, and the clonal evolution was 15% of patients. So the conclusion of this extension study was that the relapse and clonal evolution with immunosuppression were same as with immunosuppression alone, but they occurred earlier, and high risk evolution to myeloid malignancies were not increased with the addition of eltrombopag. We have a European multicentric study which is published in this year in New England Journal of Medicine. Eltrombopag added to immunosuppression. Again, the response rates are definitely better if you add eltrombopag in these patients. So the addition of eltrombopag to standard immunosuppression therapy improved the rate, rapidity, and strength of hematological response among previously untreated patients with severe aplastic anemia, even though the study was funded by Novartis. So these are the prospective studies in the first line use, where the response rates have almost gone above 80% or so. And these are when you use eltrombopag in second or more line therapy, where the response rates obviously are little lower what you see when you use as a first line therapy. Now is assessment of response. So obviously when you are giving, you need to assess the response. So these responses are assessed at 3 months and 6 months. Generally, the response criteria are based on the CAMITAS, none when the patient has still severe aplastic anemia, partial transfusion independence, and complete the hemoglobin normal for age, neutrophil more than 1500, platelet more than 150. But revised criteria do suggest when platelet count are more than 1 lakh and neutrophil more than 1000. For non-severe aplastic anemia, these criteria are little different. So what are the predictors of response? One is that if there is a PNH clone, so almost 50 to 60% of patients of aplastic anemia do have a minor PNH clone. And if they have that, it suggests they would respond to ATG cyclosporine little better. So the other predictors of response are if the patient is young, higher baseline absolute creatinine count, absolute lymphocyte count. So these are some of the factors which are predictive of response. The last part is alternative treatment in case of non-response. So the long-term follow-up, if you see these patients, so with immunosuppression, it is 50% only. This is event-free, even though the overall survival is 95% versus 65%. But that means almost 50% will have a long-term aplastic anemia-free survival. So what do you do in these patients? The first is you have to look at the causes. Obviously, there may be an exhaustion of stem cell reserve, insufficient immunosuppression, misdiagnosis, and hereditary bone marrow failure syndrome. But you can retreat with rapid ATG and cyclosporine in these patients. And the overall response rates are 30% in patients who are refractory to horse ATG and 65% who had a relapse following horse ATG. So this is important. So generally, if you are giving immunosuppression, it's the rabbit ATG plus cyclosporine. A third course of ATG can also work in those patients who are previously responded. So finally, coming to the summary. So you have a patient of severe aplastic anemia, you based on the age, sometimes 40, sometimes it is taken at 50 years. So if there is HLA matched sibling, obviously you go for a transplant. In less than 20 years of age, if you have easily availability of a mud within less than 2 months and the patient is not septic, you can go for a mud transplant in less than 20 years. But otherwise, for other patients, you have immunosuppressive therapy, ACE regimen or ATG cyclosporine or eltrombopag. At 6 months, you stop eltrombopag and taper cyclosporine, but many of these patients remain dependent on cyclosporine and eltrombopag, and you follow up this patient. If there is a relapse, you consider restarting or increasing cyclosporine, restarting eltrombopag, or a second course of immunosuppressive therapy. and based on that, you take the next decision of growth factors, androgen, and supportive care. I think that's all I have, and thank you so much for your kind attention.
Thank you, Professor Pankaj Malhotra. Beautiful review of the subject, right? Updated fully. We have a number of our colleagues present over here. If they would like to interact with Pankaj, questions, comments, your own experience, please go ahead. We have time. Maybe I can ask one question. Dr. Pankaj, do you bother about the cytogenetic evolution on L-Trombopag in these patients?
Not really, sir, because the first thing is to save the patient. So if I am not giving L-Trombopag to these patients, obviously I am taking a chance of lower response rate. So I'm not exactly bothered about the evolution in these patients by using L-Trombopag.
Mukul, you have a question.
Thank you, sir, for an excellent talk. My question is about what is the basic workup which you do in your patients before labeling them as idiopathic aplastic anemia? I mean, how frequently do you go for all the tests other than, I'll say, stress cytogenetics?
So as I said before, the history still remains the most important, history and physical examination. Many times these patients has subtle abnormalities in the physical, sometimes ears, hairs, cafe or lot spots. Many times, in the clinical practice, I have seen the residents do miss cafe or lot spots, or sometimes foot abnormalities, tongue abnormalities, teeth abnormalities. So many times they can give you the clue. So if stress, just coming specifically to your question, if stress cytogenetics is normal, then generally these days we do by next generation sequencing, looking at the inherited bone marrow failure panel. So that is one. But in some patient, somebody who is above 40 years of age, we do go for myeloid mutation panel also. Although, as I said before, it is not going to differentiate your diagnosis of MDS versus aplastic anemia, but sometimes it does help you. You will keep a watch on the patient, whether this patient is likely to develop clonal evolution or not. Otherwise, fecal elastase and many of the telomere is, all those tests are generally not available. The reason why I showed that those tests was that at least we should strive to develop those tests in the institutes and provide those tests to the patients. I hope that answers your question, Mukul.
Yes, sir. Perfectly.
Thank you. Dr. Anushree.
Muted, Anu.
Unmute.
Good evening, sir. It's so nice to see you and listen to you.
Yeah, same here. Anu was our student in PGI, so I'm seeing her after so many years now. So nice to see you. Yes, Anu.
Sir, I had two doubts. After giving ACE therapy, at the end of 6 months, are you comfortable stopping the TPO agonist abruptly? What count you are comfortable stopping abruptly? And have you ever combined L-Trombopag and Romiplostim?
Okay, so obviously you are looking at the response, and from the clinical experience, I can say that in the first month, not in the first month, but first 1.5 months, you would start feeling whether this patient is going to respond or not. At 6 weeks to 8 weeks, you will know. By 3 months, you are considerably sure, yes, this patient is kind of if somebody has achieved a partial response, then you know about that. So at 6 months, if somebody has achieved a CR, then I am going to stop L-Trombopag. Obviously, I'm not going to, continue. But there are some patients who are little slow responder, and in our again clinical experience, we have seen that even though the books mention that at 6 months you should, if the patient has not responded, you should stop all those things. But we have seen some patients, continue to respond. They are slow responder. What is the reason? We don't know. So in those patients, we do continue L-Trombopag also, and continue with cyclosporin also. We don't start tapering of cyclosporin in them. So that means they are little late responder. combining eltrompeg and romiplostin obviously is a very rare kind of a thing. Generally, we don't do, but rarely, when you are, if the patient is requiring platelet transfusion, you don't have any other option, no transplant option. Obviously, once in a while, you would like to do that, but not as a routine situation in these patients.
Thank you, Pankaj, for that wonderful lecture and the interactive session. So we will be moving on now to the second part of this webinar, and this is supported by Zydus. I'm indeed grateful to Mr. Ashish Kumar and his team for supporting our academic activities, not only for the annual conference, but also round the year for last 2 years. The subject that we have is a panel discussion for 55 minutes. This is remission in ITP with TPO agonists. Moderating this is Professor Tulika Sheth from Department of Hematology, AIIMS, New Delhi. And the panelists include Dr. A.K. Ganju, Nagpur, Dr. Anup P. Bangalore, Dr. Anushree Prabhakar, Pune, Dr. Bhavin Shah, Ahmedabad, Dr. Ganesh Jaishetwar, Hyderabad, Dr. Kishore Kumar, Chennai, Dr. Mukul Agarwal, New Delhi, Dr. Sitaram, Anandram, Bengaluru, and Dr. Subhaprakash Sanyal, Mumbai. So, Professor Tulika Sheth, over to you.
Thank you so much. And I would also like to give my compliments to Sir, because it's always wonderful to join him for these exceptionally academic meetings. This panel discussion has...
Professor Tulika, your voice is slightly feeble.
Hello, can you hear me now?
Much better.
Better? Okay, thank you. We have an excellent panel, and I would invite all of them to unmute and join for this active discussion on ITP. ITP is a problem that all of us face, and even though it is not a malignant disorder, sometimes these patients can be very difficult to manage and can be more stressful to hematologists than sometimes even leukemia patients. So the first question I have is to Dr. Ganju. Dr. A.K. Ganju is from Nagpur, and he's a very senior practitioner. When you see a patient of ITP, and what are the practical points that you need to remember and you would like to tell to any of our students who are listening for the diagnosis of ITP?
Thank you, madam, for this question. Actually, when for the first time patient comes, either he comes with a report which shows a very low platelet count, or he has some bleeding problem. Maybe patient is having epistaxis or gum bleeding or has purpuric spots all over the body. So with these two things he comes. If he comes with the report, I would always like to confirm it, because many times we see that they have normal platelet count. Especially, I will have a clinical examination before I investigate this patient, and clinical examination will give me a clue whether patient really has a low platelet count or not. The second thing would be, the best thing is to do a complete blood count, because with this I will know what is the real platelet count, and peripheral blood will tell me the differential, whether he has multi-lineage or unilineage problem. If it is a unilineage problem, it's only platelet, then I would like to see the the morphology of these platelets, whether they are small or they are normal sized or they are giant sized. I would also like to see the kind of anisocytosis with these platelets, so that I have some clinical clue and understanding whether this is because of the peripheral destruction or there is something going on differently. I would also see the mean platelet volume, which will give me some idea about the giantness of the platelets. And if our cell counter gives us an immature platelet fractions, that will again guide me how the bone marrow is actually involved. So with this, I would be basically trying to understand whether this is ITP or it's something different. If it turns out to be ITP, then I would do certain more tests, madam, to know whether there are some antibodies which are, the viral markers, etc. Or I would like to rule out, chronic liver disease, because many times we see just thrombocytopenia in these patients. So clinical details might give me some idea whether this patient is having chronic liver disease or not. Then myelodysplastic syndrome, if the patient is somewhat elderly, beyond 60 years, I would even think about that, and maybe we do further tests for this. And especially in childhood, those patients who are coming and the morphology makes me to understand that they are small platelets or they have something different. These platelets, they are looking different, or some inclusion bodies, then I would like to rule out even genetic causes of thrombocytopenia. And last is the inherited bone marrow failure syndromes. They need to be looked and they need to be considered. So appropriately, I will investigate these patients.
Thank you. That was very nice. And this shows that this is a very wide differential diagnosis, and all patients should be properly investigated before they are labeled as ITP. So, Dr. Anoop, when you see this patient who has either persistent or chronic ITP, and you're not absolutely sure patient has come to you, what are the other things you would like to know in the history for these patients?
Sure. Thank you, ma'am. To pick up from where Dr. Ganju left, history in patients with persistent ITP should be again to double check the initial diagnosis of ITP and specifically to look for other causes of thrombocytopenia, which were clearly shown in the previous slide. So past history for both the patient as well as first degree relatives may contribute. I had a patient once which was a child and not responding, and it turned out that child's father was HIV positive, and this was a very young child. It was vertical transmission through the mother. So same holds true for other infections like hepatitis B, hepatitis C, viruses which are known to cause secondary ITPs. If it is a young patient, any history of failure to thrive or frequent infections. So infections and primary immunodeficiencies I would keep in mind in a child with or a young person with a persistent ITP. Then of course, whether the bleeding symptoms and is there any relation to the platelet count. So for example, if the patient has bleeding with a relatively decent platelet count, like say 60,000, 70,000, then in all probabilities we are not dealing with ITP but with a platelet function disorder. And the same holds true if there are other family members. We may be dealing with hereditary macrothrombocytopenia than a true familial ITP, which is very, very rare. And in my practice, I have found that it will be quite useful to ascertain if the patient had ever had a previously documented normal platelet count, because this does exclude some rare conditions like congenital amegakaryocytic thrombocytopenia or bone marrow failure syndromes, inherited bone marrow failure syndromes, and so on. So just to summarize, if you see somebody with persistent ITP, it could still statistically most likely it will be persistent ITP only, but history to rule out other mimickers of ITP.
Thank you. That was very beautifully described. Excellent. I move on to the next question, and this next question is to Dr. Anushri Prabhakaran. This is always a question that people ask: to do a bone marrow or not to do a bone marrow. So in your setting, what is your practice?
Okay. So if you see the latest guideline of 2019, it does not mention about bone marrow biopsy in ITP. If we go back in 2011, it mentions that bone marrow aspiration and biopsy is not mandatory in the case of ITP. If it is a classical case with history, clinical examination without any soft signs like gum hypertrophy, bone tenderness, lymphadenopathy, hepatosplenomegaly, and if it is isolated thrombocytopenia, and peripheral blood film examination does not reveal any abnormalities in any other cell lineages, you can very well avoid a bone marrow aspiration and biopsy. Coming to the second question, the causes of thrombocytopenia. Of course, one has to see whether it's an acute presentation or if it is a chronic and recurrent presentation. If it is isolated thrombocytopenia or if it is a pancytopenia. So our differential will base on the clinical presentation as such. But broadly, we can categorize causes of thrombocytopenia into two groups. Cases where there is accelerated platelet destruction and cases where there is decreased platelet production. So in category where there is increased platelet destruction, the most common what we find is primary immune thrombocytopenia. However, it may be associated with other autoimmune diseases like SLE, rheumatoid arthritis, CTD, etc., or with common variable immunodeficiency, other immune disorders like CVID, etc. If it is an acute presentation, it may be thrombotic microangiopathy like TTP, HUS, heparin-induced thrombocytopenia, sepsis and DIC, which is sepsis related or non-sepsis related. Of course, one has to keep in background chronic liver disease, portal hypertension, and other causes of hypersplenism. And coming to the other group, where there is reduced platelet production. Two very common things which we have to keep in mind, especially if there is anemia and leukopenia, are evolving aplastic anemia and myelodysplastic syndrome. Other things to inquire is history of drugs. You have to review all drugs which is taken by the patient in the past. Third would be to see if there is any infection associated, especially viral infections, HIV, EBV, CMV, etc. Nutritional deficiencies one should not forget, like vitamin B12 and folic acid deficiencies. Other most important things where the bone marrow is mandated and there is pancytopenia, not isolated thrombocytopenia, is infiltrative processes like acute leukemia, lymphoma, myelofibrosis, secondaries in the marrow, etc. And the last one would be inherited bone marrow failure syndrome, where there is a broad category like Fanconi anemia, dyskeratosis congenita, Shortman-Diamond syndrome, congenital hemikerocytic thrombocytopenia, etc. One common thing which we see here, where there is large platelets and mildly reduced platelet count, is especially in people who are from northeast area, is Harris platelet syndrome. So these are the two categories of thrombocytopenia.
Thank you, Dr. Anutri. I think you've summarized that beautifully. And as you rightly said, some of these other more serious conditions that cause pancytopenia can sometimes present with isolated thrombocytopenia. And that is why it's very important to keep following these patients. Excellent. So thank you. And I move on to the next question. Dr. Chepsi Philip.
He is not there.
Oh, he's not there. Oh, okay. Is anybody else volunteering to do this question on?
Ma'am, I can take that.
Yes, please. Wonderful. Thank you, Dr. Mukul.
So, ma'am, as has been nicely highlighted by Dr. Ganju and Dr. Anushree, that ruling out other causes of thrombocytopenia in a patient of ITP is very important. And in such a scenario, platelet size is one of the important parameters which provide us clues to the diagnosis in this patient. So, like you have highlighted here, patient with small platelets, the peripheral smear, when you see the platelets are smaller in size, and on the counter report, if the MPV, which provides the estimate of the mean platelet volume or the platelet size, if that is low, that this is suggestive of viscotriglyceride syndrome or the X-linked thrombocytopenia. Vis-a-vis, large platelets are seen in Bernard-Solier and MYH-related thrombocytopenia. Although rare, it is important to know these causes and realize these clues, because these are the conditions in which patients, first, they do not respond to immune suppressive therapy of ITP. And second, there are associated abnormalities which may be there, like in viscotriglyceride or inherited bone marrow failure syndrome. So it is very important to recognize these symptoms, have a proper diagnosis for these symptoms so that appropriate management and specific management for them can be prescribed.
Thank you. That was really excellently described, and thank you for stepping in at the last minute. We had a wonderful discussion again at Dr. M.B. Agarwal's meetings where Patricia Norris had come, and she talked about many familial giant platelet syndromes. So again, just because you have giant platelets, it does not necessarily mean that it is ITP. So some of these giant platelets can be seen in ITP, and sometimes giant platelets may also be in inherited disorders. And there's a very nice paper again by Dr. Patricia Norris, where she's looked at different platelet parameters to differentiate this. And they had found that there were variations when you do sort of complex calculations about the mean platelet volume and diameter to differentiate. So this is something to keep in the back of your mind. The next question is, what are some of the ITP related emergencies that you've seen and we need to be aware about? So I call upon Dr. Bhavin Shah to take this question, please.
Thank you, madam. Usually the ITP related emergencies, the most common is the bleeding, and we are worried about the ICH the most. Cutaneous bleeding is not a major concern, but then if there is a intracranial hemorrhage or subarachnoid hemorrhage or profuse hematuria or hematemesis or hematochezia, these all are a concern because of the ITP. Fortunately, in patients with persistent ITP or chronic ITP, the chances of major bleed are less than 1 or 2%. So they are not very common. But yeah, in many patients with acute ITP, we see more cases of intracranial hemorrhage or a profuse bleeding. The second, thrombosis is another uncommon side emergency. Because in ITP, there are young activated platelets are there in the circulation, and there are chances of 2 to 4% chances of thrombosis, though we don't see very commonly in our practice. But post-splenectomy, we many times see patients presented with thrombosis. Same way, thrombosis can occur because of TPO agonist. It is a rare side effect, but it can occur with TPO agonist. Then treatment-related side effect, the glucocorticoids which we use as a first-line treatment, hyperglycemia, hypertension, gastritis, they are the common problem. The infection is the another concern. Whenever the patient have uncontrolled sugar, the infection can occur with not only steroids, but all other immunosuppressive treatment. With NTD, we can see a hemolysis, though NTD is now not very commonly used by us. Dapson syndrome, I have not seen in any of my patients, but then theoretically it is possible. And each and every other immunosuppressive drugs have their own side effects, like IVIG can cause many times acute renal failure. So these are the emergencies, though they are very uncommon, but we have to always keep in mind when we treat the patients with ITP.
Well, thank you, Dr. Bhavin. That was really good. Can I just ask you about platelet transfusions? When do you use them in ITP patients? Because in a lot of outside patients, when we see them, many of them have received platelet transfusions, and often they complain that they were given platelets, but then there was no increase in the platelet count. So when do you recommend platelet transfusions in a known ITP patient?
Yeah. So as we all know that there are antiplatelet antibodies are there. So whatever the blood platelet we transfuse, they will also get destroyed because of these antibodies. But we usually transfuse the platelet when there is an acute bleed. So when there is a major bleeding is going on, or bleeding which is not controlled with the medicine or antifibrinolytic agent, in that case we transfuse them with the platelet with the intention that will reduce the intensity of the bleed. Many times the patients who had thrombosis, and along with that we have to give something as an antiplatelet or anticoagulant. In that case, we give platelet transfusion to facilitate the anticoagulants or antiplatelet drugs along with that.
Okay. So very good. So you highlighted two important areas. And if you're giving platelet transfusions, it's important to give it under cover of steroids or some other medication. Thank you. Thank you so much. I call upon Dr. Kishore Kumar to talk about a case. Dr. Kishore?
Kishore is not there.
Okay, sorry. I'm not able to see the panelists. Again, I would call upon anyone to answer this, Dr. Ganesh or Dr. Mukul or anybody.
Good evening, madam.
Good evening.
So, yeah, this is a 34-year-old business executive, and his major issue with the ITP, chronic ITP, which is being there for 4 years, is chronic fatigue. So, and apart from that, he has this bruising, petechiae, and wants an active lifestyle. So, essentially, all the treatment options like the his chronic ITP. So uh, the steroid sparing therapeutics which maintains the good platelet count with addressing the autoimmune etiology. So probably under these case, the two important therapeutic possibilities which can be really helpful to him addressing the underlying autoimmune disorder, that is ITP. So first one is rituximab, which has the best possible chance of treatment-free disease control for at least 2 to 3 years in about 60 to 70% patients. So, if looking at the pros and cons of rituximab, is a business executive. Discussing him the pros and cons of rituximab, if he agrees for the minimal toxicity of mostly the infusional toxicity and little immunosuppression, that will be my first choice. And second one is TPORs, which what we have seen in our clinical practice in chronic ITP patients. Apart from improving or maintaining the therapeutic target platelet count, the TPORs, both eltrombopag and romiplastin, patients on these drugs, they also have a
I think so. We have a little bit of connectivity issue. So TPORA, yes. Okay, I think we'll go to the next question. So Dr. Ganesh had said rituximab, which is a very good option, and TPORA. So two of those options are available to all of our patients. I have another case of a 20-year-old female who's been diagnosed with ITP 6 months ago. And she's very interested in rituximab because just like Dr. Ganesh said, she had heard this was very good. So Dr. Mukul, what is your opinion of rituximab in a young female who has had ITP for not a very long time?
There is a published study about rituximab use in young females. So the study clearly highlighted that patients, especially females and young females less than
in the reproductive
age. 40 years of age, and those with the ITP duration less than 12 months as well as less than 24 months comparatively have a better outcome as compared to the patients who have ITP duration of more than 12 and 24 months. So in such a scenario, these patients tend to have a longer lasting and a higher chances of sustained response as compared to patients of chronic ITP who have a duration of ITP of more than 2 years. So as has been beautifully highlighted in this chart, we can see that the CR rate in these patients can be of the tune of around 60%, which is pretty handy for and leading to almost responses or long-term responses cure in up to, we can see that almost 60% of the patients are having a good CR at 6 years, which is a kind of curative for these patients. So she qualifies for, she's a good candidate for rituximab. Meanwhile, there is a good chance that she might be having some autoimmune condition. So if evaluated for that, rituximab is likely to help in that as well.
So this paper actually used rituximab and 3 cycles of dexamethasone, but there are also similar studies where the same result was with rituximab alone also. So exactly as you said, in these younger women, and especially those who had not had chronic ITP for a very long time, so less than 2 years history, this is a very good therapeutic option. And the doses of rituximab?
Doses is conventional. Most of us usually do use a conventional dose of 375 milligram per meter square, 4 doses, and tend not to repeat it after the first course. And maybe put the patient on the lower doses of steroids or other agents. So this provides a good sustained response. Although not good or large randomized studies are there, but there are anecdotal reports and small patient data which say that a dose of 100 milligram per meter square also works to a good extent in many of these patients.
So I think if affordability is an issue, this could also be
Yes.
an option.
Yes.
Yeah, excellent. Thank you so much. So when using TPO RAs, is Dr. Ganesh with us again? Hello?
I think I can answer that.
Yes, yes, madam.
Dr. Ganesh
Yes,
has
ma'am.
joined back. Thank you. We lost your connection. So welcome back. So
Sorry, ma'am.
no
Apologies. Yes,
problem,
ma'am.
no
Thank you.
problem. So what are your criteria for selection of TPO RAs? Because as you know, we have 2 available products in India. We have also the innovator for L-thrombopag, and we have generics. And then for the Romiplastin, we have several generics. So the cost is actually not so much of an issue. So how do you choose, if in your patients a TPO RA?
Yes, ma'am. So those patients who are very good in their compliance, who can follow the dietary guidelines of this L-thrombopag, who are committed with all these, upfront educative sessions. So those are the ones whom we usually opt for L-thrombopag. But majority of our patients after these generic romiplostins have come into our clinical practice. So majority of our patients are on romiplastin. There are many advantages of romiplastin. Number one is ease of administration, the spacing once a week, and also the third one is the cost. Having said that, there is no literature evidence of superiority of one TPO analog against the other. So, because the response rates to both of them are in somewhere between 60 to 80%. In fact, the rapidity of response is an advantage with romiplastin because the response is seen usually within 1 to 2 injections, that is 1 to 2 weeks. So that is one reassuring fact that the patient are happy to take 1 to 2 injections and see the platelet count going up above 50,000. That's a very important milestone for them because the psychological reassurance of platelet responding to this drug is very crucial. And having the previous experience with L-thrombopag, even the most of the literate patients, many a times they tend to err on this, dietary guidelines or taking L-thrombopag with other drugs. That is always a common problem, and finding out the causes of failure is always a challenge. So our practice has evolved to start with from L-thrombopag, now romiplastin. So most of our patients are on romiplastin. Exceptional patients who have failed romiplastin, they are on L-thrombopag.
Right. So we actually are going to talk about switching too. There is one study where people had looked at TPO RA levels, thrombopoietin levels, and they had found that. So this is again a paper from Dr. Puta, who is really the main person for this, and he had found that patients were more like if they had a higher baseline TPO level, they were more likely to respond to romiplastin. So this is just an interesting thing. We are doing a study on this and trying to see if this works for our patients as well. But on the whole, we don't really have any predictors. And so we start off with one. And as Dr. Ganesh had rightly said, there has to be a discussion with the patient on which one they're going to be able to manage. And then that is kind of done. So thank you. Now we move on to the dosing of TPO RA. So Dr. Sitharaman, when you start one of the TPO RAs, what is the dose that you usually start off with?
Thank you, ma'am. So with romiplastin, as I think most of us, what we do is because it's available as 250 micrograms, so we don't like not to waste the vial. So we probably just start with 250 micrograms. Although traditionally, or the recommended dose is 1 microgram per kg body weight weekly, and then escalate or de-escalate depending on the response. But my starting dose is generally 250 micrograms. But fortunately, I think we've got now preparations where we get a lesser 125 micrograms as well. Recently, I've been slightly worried about using 250 because we've had seen patients who are having erratic increase of platelet count as high as 8 lakhs and 10 lakhs. So that's always a worry. So I'm slightly more cautious. So if the patient is at a risk of high bleeding, if the patient has, say, wet purpura, and they can't afford IVIG, then I probably would go with a higher dose. But if patient is just a chronic ITP who's failed multiple lines therapy, who we don't feel is at a high risk of bleed, then I would probably go with the 125 microgram per kg body dose for romiplostim. As regards to L-Trombopag, it's a standard dose. We start with 50 milligrams, obviously taking and advising regarding all the dietary precautions, and then I get up by 25 milligrams. But most of our patients don't end up taking it. So to be honest, I think romiplostim works as well as L-Trombopag. And the other thing which I've seen with romiplostim is we're seeing patients who get a prolonged duration of response. So we have patients who take it 10 days, twice a week. Got a couple of patients who even just take it once in 3 weeks. So after a period of time, patient themselves will realize that the frequency at which they require the injection.
So thank you. Those were really good, important, practical points. And I do recall from one of Dr. Puta's seminars where he said that even if the platelet count goes to like 10 lakhs, these patients are not at risk for thrombosis. So that I thought was very interesting. But you're right, we've also had a few patients where the counts have suddenly skyrocketed. And I think your suggestion of selection of which patients to start at a higher dose and which to start at a lower dose is a very good practical point. Thank you.
Thank you.
So Dr. Sanyal, is Dr. Subhaprakash Sanyal here? Very good. Would you like to comment on ITP patients who require to be on antiplatelet drugs? And what is the platelet cutoffs that you want to keep these patients at? And how do you manage their anticoagulation? This is always a difficult problem.
So good evening, madam. I think this is a very important issue in the hematology, and we have recent years we have managed a couple of patients like this with a closed liaison with the cardiology friend. So here the risk benefit is the most important thing that we have to assess. And the CABG, post-CABG is little easier to manage than the post-angioplasty, because CABG, the standard norm is that patient needs a single antiplatelet agents to continue. And this is a very few area of ITP where the platelet count more than 20,000, no active bleeding, no treatment required philosophy don't work. So single antiplatelet agent actually required, and in our institute, we follow the 50,000 platelet count is the threshold for that. And my cardiologists don't mind if I stop the antiplatelet for a few days to few weeks in view of the platelet count of 20,000, 25,000. Because our concern is that if there is a bleeding happens and some bad bleeding happens, like a CNS bleed or something like that, catastrophic bleeding, that we can lose the patient. So that is one important thing here. So 50,000 cutoff is the standard practice we do. And therapy options, in particularly in what I prefer here with the chronic ITP cases, particularly very low dose of steroids, say 2.5 milligram to 5 milligram of Visolone with a TPO mimetics works very well for us. We try to keep the platelet count at least 70,000-80,000 marks so that me and cardiologist are both are comfortable and both are managing the patients quite efficiently. Honestly speaking, in our practice, whatever we've seen in recent past, that we don't have encountered any increased incidence of thrombosis in our practice. So we are now getting much bolder and using these combinations very well in this particular group of patients.
Thank you. That is really good. The other thing that we have sometimes done is in discussion with the cardiologist, we've in some patients, we've reduced to one antiplatelet drug, especially for patients where we find it difficult to keep their platelet count 70,000 or so. So if their platelet count is 40, 50,000, then we sometimes go with one antiplatelet drug. What is your experience?
Actually, ma'am, in our institute, the cardiology is very clear cut. Post CABG patient use only single antiplatelet.
Okay.
So that way, I told you the CABG patient is easier to handle. So question problem happens when there is a post angioplasty patients. And madam, post angioplasty, they start with the ecospirin with a newer drug called Brilinta combination. So that is a little difficult times. And honestly, we have a couple of patients like that also in our recent past. So in that case, unofficially, we just discuss among ourselves, and we try to keep 35,000 platelet is the threshold. But there, the cardiologist is not very comfortable in just, and depending on how far you are from the angioplasty event. So if it is in 3 months, a little difficult. So we have to manage all these things. We have to combine 2-3 drugs to at least push the platelet count more than 40,000-50,000 mark. So that is how we do. But it is a very case-to-case basis we do, madam. But CABG is more easier to handle.
Agreed. Thank you. That was very nice. So, Dr. Ganju, we sometimes have patients who have ITP, but they also may have a chronic liver disease. So how do you manage a patient like this? Unfortunately, liver disease is also very common in our country. So if you had to use a TPO-RA, which one would you prefer?
Well, madam, the two TPO which are available to us are Eltromavag and TP and the Romiplastin. Out of these two, Romiplastin seems to be a better one than the Eltromavag because you have more chance of venous thromboembolism with Eltromavag in liver disease. And rightly, a new drug, which is Evertromavag, which has been extensively studied in chronic liver disease where it has been used. I think that would be the drug which one should be able to use in these patients without caring about the venous thromboembolism. So I think Evertromavag, which is not yet available here, if that's not, then Romiplastin should be the drug.
And L-thrombopag does in some patients cause liver toxicity. So we sometimes see elevation of liver enzymes. Correct. Thank you. That's very nice of you to share your experience. There's if patients are not responsive to one TPO-RA, so for example, if they had been put on Romi or if they had been put on L-thrombopag and they're not responding to that one, what is your experience with switching, and has anybody ever used any combination of TPO-RA? So this is a general question. Anyone can share their experience of switching or combinations?
Ma'am, can I take that question, Dr. Anup?
Yes. Hello.
Yeah, so the first question I'll split into two. So firstly, when do you give up on the first TPO-RA? So when do you say that it's not working? And then what is the experience with switching? So it is very difficult to follow the standard recommendation in our Indian population because of the cost issue and the trust issue from the patient. So if my patient is on, say, L-thrombopag and there's no response, and if I follow the standard recommendation for waiting up to 4 months, I would probably lose the patient to follow up. So I would consider switching much earlier than that. If it is Romiplastin, the recommendation I think is 1 month on the maximum dose, and the maximum dose being 10 microgram per kilogram per week. So in clinical practice, this doesn't happen. We have to consider about switching or changing to some other modality much earlier. I have switched both ways from L-thrombopag to Romiplastin as well as from Romiplastin to L-thrombopag. What I have seen is that when we switch to the parenteral form, for some reason some patients respond more than the other way around. So I've had better outcome switching from L-thrombopag to Romiplastin rather than from Romiplastin to L-thrombopag. In terms of that second question, combination of two thrombopoietin receptor agonists, I have never combined them. I would welcome other panelists' viewpoint.
So your experience of switching from L-thrombopag to Romiplastin is actually shared in a publication where they also found that, and that may be related to Dr. Kuter's paper where he feels that Romiplastin is a stronger TPO agonist. So again, I don't have any experience of combination, and is there anybody who has used it in the panel?
Dr. Anu here.
Yes, go ahead.
In ITP, I have never combined these two drugs, but in aplastic anemia, out of desperation, I have combined. And it's like a mixed result. There is one patient who has achieved a platelet count of 75,000 consistently with both the drugs ongoing.
So there is again a publication of about TPO-RAs from Dr. Kuter. It's sort of a review, and he has suggested that it can be combined. The other thing he suggested is to add low-dose prednisolone to a TPO-RA before you kind of give up on the TPO-RA. And that's something that we definitely do if we're treating with a TPO-RA and we're not seeing a good response. We add steroids, and we usually will be able to see a response in 1 or 2 weeks. But the combination has been suggested, though it wasn't described in that. Now,
There was a catch. Sorry. So
ahead.
there's a
Yes,
catch in that switching from one TPO RA to another. So if we are switching because of lack of response, chances of response to the TPO RA are lower as compared if we are switching, if there is a cost issues, financial issues, or if there are side effects.
Okay.
Or intolerance in the patient. So in those scenarios, if you're switching because of intolerance or side effects to a one TPO-RA, then in that scenario, responding to the other maybe of the tune of 60 to 70% even.
So in this paper, this was discontinued because of lack of response. And even then they did find that it was worth it. So I think the reason why, but agreed, there would be some patients who may not respond to another TPO-RA. So it wasn't 100% response. But before we give up on this group of drugs, it's worthwhile giving it a trial. But definitely, I think your comment is well taken. And we see that in other diseases, if you switch for toxicity, you may have a better response. So point noted. Now, there are some patients who have a good response, and we may be able to do treatment-free remission with TPO-RAs. And in the literature, it's described that about 30 to 40% of patients on either of the TPO-RAs that we have available may go on to have a sustained response. And this is a study from the UK where they reviewed practitioners to see their experience, and they actually had a very high experience of 65 to 80% of their patients were having a sustained platelet count of 50,000 or more, even after stopping the TPO-RAs. So would any of the panelists want to share their experience with treatment-free remission after using TPO-RAs, and what do they feel? Is that there with both of the TPO-RAs or one of the TPO-RAs?
Ma'am, Saniel here.
Yes, please.
Yeah. I fully agree with ma'am that TFR is possible, and it's quite a significant number of patients going into the TFR. And I agree with you, around 40-50% patients, they complete remission and then maintaining the whole stuff, maintaining the platelet count reasonably well. My experiences is more better with the L-thrombopeg. Ramiplastin, it is little less. If I don't have the exact data about divide the patient, but around, say, I can roughly tell you around 70% with the L-thrombopeg and 30% with Ramiplastin. But one question, ma'am, I want to ask you here, that is one very important. So we always go by the simple parameter that more than 20,000 platelet and no active bleeding, and then we stop the drug, right? And they do quite well. But many patients in the ITP present with the fatigue, and fatigue is extremely bad fatigue. And now we realize that the fatigue is a part of the ITP. So if your patient is managing a platelet count of 80,000, 1 lakh, 1 lakh 10, and extreme fatigue is on, do you believe it to continue the treatment or not? That is my question to you and any other panelist.
So I would like to say that usually if the platelet count is 70 to 80,000, in my experience, the patients usually are not experiencing fatigue. But again, that may not be there in all of the patients because all patients may have different problems. We tend to see more fatigue when the platelet count is on the lower side.
Yeah.
So again, I welcome any comments from others if they've had similar or different experiences.
Yeah.
Totally agree with you.
Yeah, madam. I also agree with this because most of the patients who get their platelets up, their fatigue is off. So most of these patients do well when their platelets are going up. And there, we had some patients who were on L-thrombopeg, and since it was expensive, they stopped after 2 or 3 months. And then when they came back, their platelets were okay. They were around 30, 40,000. Then we started from 10,000 was the baseline. So I think this TFR is possible with L-thrombopeg.
So thank you. And in fact, your experience has been echoed in publications where TFR has been reported with TPO agonists for as short a duration as 2 months, and but the majority of them have been 6 months or longer. So again, this is something that we don't really know. Again, I do have some questions about TFR in ITP, because we do know that we have patients who do have spontaneous remissions also. So again, we have to be a little bit careful. But in one of the things that I had been reviewing, often what they do is when they are attempting a TFR, they, rather than what we do in CML where we abruptly usually stop, in this they have defined where they reduce the dose of the TPO RA, and in fact in this they actually have gone to like alternate day, and then just a few times in a week, and then gradually reducing it for L-thrombopag. So this is something that again we can see, but I think it would be really nice to do a study. And I think the question about the fatigue is very important, because I don't know that many of us are actually using any scales to assess it. But I think we should do that, and this would be a very important thing to see. And if fatigue is definitely a problem, then I don't, if affordability is not an issue, then perhaps treatment can be done. Obviously, we don't need to have the platelet count normal, but at a level where the patient has less fatigue would be there. So pregnancy and ITP, anybody who would like to talk about their experiences of managing pregnancy and ITP, and what do you do differently? Anybody?
I can take that question.
Okay. Yeah, please go ahead, because we do a lot of pregnancy and ITP at our center, please.
So IVIG and maybe around 0.5 kg up to 0.5 to 1 kg of milligram per kg of steroids are the standard treatment for most of our ITP patients. And we are very liberal in using IVIG frequently, maybe on every 3 to 4 weekly in these patients. So that is the standard treatment for ITP in pregnancy. But many of these patients do not respond. In such a scenario, what we are left are with our very choices. So that choice could be kind of off-label or infrequent choices in the form of maybe cyclosporin or rituximab, or off-label use of TPOR. So these are the things which we have used in some of the patients with okay kind of results.
Azathioprine is actually approved in pregnancy and ITP, and it's actually not a drug that we use a lot in ITP at our center. And it's not something that I have actually used a lot in pregnancy. So I agree with Dr. Mukul, but it is an approved drug in pregnancy and ITP, which I thought was a little unusual. But it's also something that Dr. Drew Proven and others that we've done webinars with have recommended. The other thing that they have recommended is, as we do IVIG frequently, they recommend that because they do not think that high doses of steroids should be used in pregnancy. Maybe using up to 20, 30 at the maximum for short periods, and then going down to lower levels of steroids is recommended because you may mask infections and you may have other problems. So if you're not able to get IVIG, we are very lucky. We have a Janani Suraksha Karikram by which we can get free IVIG, and with the usual low dose steroids, then TPO-RA have been done, and Dr. Mukul has successfully managed several refractory ITP patients in pregnancy who had come during the lockdown and were very difficult to manage. So you've highlighted that very nicely. And at the same time, you must make sure that you are actually dealing with ITP and not dealing with something else. So these are just some of the...
Can I just...
Please,
another drug which I found useful is HCQs in pregnancy, particularly if they've got ANA positivity. Because of the category of patients I see are basically from lower financial strata or low middle class. So I have used HCQs successfully, particularly if they are if they've got ANA positivity. Just a comment.
So that's a very good practice point. Thank you. Excellent. So we talked a little bit already about the refractory to TPOs. Where is splenectomy in your practice? Does anybody want to talk about how frequently they do splenectomy, or is it less frequent now?
Madam, I'm Dr. Bhavin. I can take this question.
Yes, please, please.
Yeah. So splenectomy nowadays, with the availability of rituximab and TPO-RA, we are now using it at a later stage. Usually for up to 1 year, we don't offer splenectomy to any of our patients. But after 1 year, if the patient is refractory to rituximab or TPO-RA, we can obviously offer them splenectomy. Many times we see patients who are not very affording for rituximab or TPO-RA. In that case, if they are not responding to steroids or some of the other immunosuppressive like dapsone, azathioprine, in that case, we can offer them splenectomy. But it usually, because there is a chances of spontaneous remission for initial 1 year, we don't offer splenectomy to most of our patients.
So your experience is very similar to us. Earlier, we used to use a lot of splenectomy for patients who were not affording treatments, but now we very rarely do it. The other thing is that there are patients who may have complications later on in life, and there have been some publications from the West about increased risk of complications. So this is now less used in our scenarios. So if menorrhagia is a major problem, does that affect your choice of therapy? And in the ITP patients, are there other drugs that you use concomitantly? How do you manage these patients? Because many times the platelet count may be, 40, 50, 60,000, and yet they have menorrhagia. So again, this is an open question. Anybody would like to share their experience?
I'd like to answer that. So we should treat menorrhagia as a site of bleeding. So if a patient is having bleeding, let's say even at 20, 30,000 platelet count, we should target a higher platelet count with added therapy specific to ITP. Plus, we should be, there are other therapies which can help in reducing menorrhagia. These could be liberal use of tranexamic acid first, and then hormonal therapy, either in the form of progesterone tablets or in the form of IUDs, Mirna, which is commonly used. So these are the things, or even GnRH analogs for such patients. So we should be more open to such ideas of using other methods to decrease menorrhagia in these patients, especially if they are not having other sites of bleeding. In addition, assessing their iron stores and added iron therapy that improves their quality of life as well.
Excellent. So you've highlighted all the important things. So there are many concomitant therapies. Working with your gynecologist to do that is really important. Another strategy that can be sometimes used, particularly in older females, would be danazol. And there are several studies from Korea and other places where they've actually found that danazol could also help. And this could be actually a drug that works both for ITP as well as for the menorrhagia part. So that's just one extra thought that could be there if the other things that Dr. Mukul described don't work. So this is a pediatric case. I think we have enough time to do one last case. So this is a pediatric case who presents with bruising and has been on steroids, but never really had a great response. The platelet count always remains around 30, 40,000. And on looking at some old records, we find that his platelet count was always low. So this was brought out earlier by several of the speakers, where you should have at least some documented normal counts. So this patient is now 4 and he's never really had a normal platelet count. So Dr. Mukul, this was your case. Do you want to go ahead with this?
Yes, ma'am. Ma'am, so this is a classic case and with lots of pointers that this may not be ITP. First of all, this problem has started in the newborn period, which has shown low platelets. So ITP in newborn and infancy is a rare diagnosis. It's not a common diagnosis. I would not say rare, but it's not a very common diagnosis. And that is a time when the patient is presenting with bleeding, then other inherited thrombocytopenia syndrome should come into mind. Then the patient has not responded to IVIG and steroid. This again, we are looking at around 10-20% of the patient who don't respond to immunosuppressive therapy. This is another second clue to our diagnosis. Then the pediatric patient going into a chronic ITP, this is a third clue that she is falling into that around 20% of the pediatric patient who go into chronic ITP. With such less common chances, we should rule out inherited thrombocytopenia in such cases and extensively evaluate for that.
So, along with all these inherited thrombocytopenias, things like ALP syndrome and immunodeficiencies and inherited bone marrow failure syndrome. So perfect. So this is something that we must remember. And in fact, I remember when we had so again, another thing that can sometimes be there is that you can have a family history if the family members also have low platelet counts, then you may be dealing with a familial ITP. And this is again from Dr. Norris's paper. And I think if all of us look at the chronic ITPs that we have in more detail, many of us may actually find that some of these patients are actually not chronic ITP, and particularly if they have a family history of malignancy or they have other family members who have ITP. So just a thought that even though we were talking in detail about ITP, but sometimes ITP is not ITP. And the goals of therapy have so far only been to reduce the risk of bleeding, and we wanted to avoid long-term complications of therapy, and we just wanted to keep the platelet count above 20,000 and prevent bleeding. But I think now with the TPO RAs, we should aim a little bit higher and we should have better goals. Of course, there's still not a lot that we know about how to choose therapy. We're not there where we can look at a patient and say, okay, you're going to respond to this. We do have some idea about rituximab and a few other things, but we're still not there yet to predict which patient will do better with which therapy. But I think looking for cure is definitely going to be something that we should aim for. And any last comments from any of the panelists, any points that we've missed or anything that they would like to highlight? And so over to the panelists before we hand back to the organizers. Any last comments?
Thank you, Professor Trikashet, for that wonderful interactive session. We have a couple of minutes. Can you take up one or two questions from the audience? So one is a question about how do you manage chronic ITP once there is a failure of steroids, azathioprine, MMF, and the TPOs?
Often then we look at combination therapies, different combinations can be tried. If you've tried both of the TPO RAs, you could try, you could use a combination of regimens. We have found that dexamethasone pulses are often very effective. Dexamethasone, rituximab, these are options that haven't been used in this patient, and they should definitely be given a trial. We kind of keep splenectomy very last. So I don't think that everything has been tried. And again, just make sure that this is ITP. Before using rituximab or before we plan for something like a splenectomy, we often redo the bone marrow. We've had some patients who at our own center were labeled as chronic ITP, but when we repeated the bone marrow after a few years, because we were planning rituximab, we actually found that they were myelodysplastic syndrome. So again, it's worth revisiting the diagnosis.
Thank you. Very briefly, if you can, any one of you can answer one more question by Dr. Arihant Jain. How do you rule out or suspect drug-induced ITP? Which drugs and herbal products do you particularly look for?
So we've actually seen ITP, thrombocytopenia, drug-related to things like azathioprine, and it's very common. We've seen thrombocytopenia post many antibiotics. So patients who have been admitted for pneumonia, they often we see thrombocytopenia. So obviously you'll have to get the drug history and find out what drugs they've been on. Herbal products, there are many, there's a whole list actually. And again, if you have patients who've been on Ayurvedic or herbal medications, it's a good idea to find out. They may not know what they've been actually taking, but if they've been taking something, it's worthwhile getting them off it. For azathioprine thrombocytopenia, I actually had one patient, we did several bone marrows in him, and it took him a good 3 or 4 months of stopping the drug for the platelet count to improve. So, even though we use it for thrombocytopenia, but sometimes these drugs can also cause cytopenia. Any other panelists can share their experience too.
I think just because of the shortage of time now, we will stop here. Thank you so much, Professor Tulika Sheth.
And thank you to all the panelists. Thank you.
Yeah.
Thank you, madam. Thank you.
Dr. Ganju, Dr. Anup, Dr. Anushri, Dr. Bhavin, Dr. Ganesh, Dr. Kinkul, Dr. Sitaram, and Dr. Sanyal. Thank you, all of you. And once again, thanks to Zydus for supporting our academic activity. We move on to the last part of the webinar this evening, and that is supported by Jensen. And this is related to optimizing novel agents and myeloma, a case-based discussion. And this will be moderated by Brigadier Dr. Satyaranjan Das, is Professor and Head, Pediatric and Clinical Hematology, Command Hospital, AFMC, Pune, former Professor and Head, Department of Clinical Hematology and Stem Cell Transplantation, Army Hospital, RNR, New Delhi. We have a wonderful panel for him, Dr. Prathamesh Kulkarni, I think he has not yet joined, from Mumbai, Dr. Ashok Meshram from Mumbai, Dr. Hamza Dalal from Mumbai, Dr. Nidhi Jain from Ahmedabad, Dr. Lingaraj Nayak from Mumbai, Dr. Abhishek Dudatra from Ahmedabad, and Dr. Nishad Dakate from Nagpur. So over to Brigadier.
Sir, thank you very much, sir. I'll just share my slides, sir. Okay. So slides are visible, sir?
Perfect.
Good evening, everybody. At the outset, I'd like to thank Dr. M.B. Agrawal, sir, and the Mumbai Hematology for giving me this opportunity. So I welcome all my panelists. This topic is optimizing novel agents in frontline and first relapse multiple myeloma. It's a case-based discussion. I'll be presenting 3 cases of my patients only from Pune, and they are the real cases, and the treatment may not have been what will be discussed because of our institutional policies. So just coming to the history of myeloma treatment, if we look back, Sarah Newberry in 1840, there was nothing to offer. And if you see all the way along, starting from Elflan in 1950, then all these novel agents coming in 90s and 2000, like thalidomide followed by botensilimab, lenalidomide, pomalidomide, carfilzomib, and then daratumumab. All those have changed a deadly disease like multiple myeloma, which was a death, was severe, later to a chronic disease, and now possibly cure. All those have been because of these novel agents, which have been playing a great role in management of this disease. So, slides not changing, I'll just. Okay, so now I'll come to the first case. The case is of this year, February 2020. This is a 73-year-old retired Air Force officer. He was a known case of hypertension and ankylosing spondylitis. He presented with EG fatigability. He was investigated in a local ECHS, and they found anemia and raised creatinine. He was referred to us. He had anemia, severe anemia, and the creatinine was high. So he worked up for myeloma. He came out to be a lambda light chain disease. His lambda FLC was 46 kappa and more than 12,500 lambda. Bone marrow was consistent with multiple myeloma. We did a PET also. There are multiple lesions in spine, skull, rib, and maximum SUV was 4.5. We did a USG KUB. Right kidney was 9.5 centimeters and left kidney was 10 centimeters. And they were raised ecostructure with loss of corticomedullary differentiation. We routinely send all our bone marrows for karyotyping because it is done in-house. And the karyotype showed 1Q gain, 6Q deletion, translocation 11-14, and deletion 13 and deletion 17. We also outsource our myeloma panel, so which showed all three except deletion 17. I don't know why this discordant was there, but anyway, this patient was diagnosed as multiple myeloma, light chain disease with a stage 3 disease. Coming to my first, I don't know, sir, whether Prathamesh has joined or not. I think, yeah, you have joined.
I'm here, sir. I'm here.
Thank you very much, Prathamesh. Yeah. And your question is, any additional evaluation you would like to have in this patient? Why not kidney biopsy? What is the role of kidney biopsy? Risk and prognosis in myeloma. Is this patient transplant eligible? Yeah, I have been asking you the basics because our PGs will listen what are the basic of multiple myeloma.
Right.
Dr. Prathamesh, please.
Thank you, sir, and my apologies for joining just on time. It's a very straightforward case from what we look, sir. Additional evaluation, I just think that you have not mentioned immunofixation, and I assume maybe you have done because you mentioned the light chain myeloma. So I assume that immunofixation
it has been done. It has been done.
Heavy chains are negative, right?
Heavy chain negative, yes.
Right.
We found 1.2 gram of protein in the SIAP, but they were all light chains.
Right. And one more thing, sir. Apart from everything that we need, talking from the supportive care point of view, I would like to know the calcium and vitamin D levels because that makes a lot of difference during the treatment. So vitamin D, I think we have been through a lot of talks and panel discussions where they say that vitamin D is necessary. So yes, vitamin D we will do.
Vitamin D has not been done in this patient, but calcium was normal, 9.3.
Right. Okay. So going to the diagnostic criteria for myeloma, this is how we classify it into MGUS, which is very benign or a pre-malignant phase of myeloma. Smoldering myeloma, when there is an actual M protein high, there is actually plasma cell dyscrasia, but no myeloma-defining events or no end organ damage. And then the third is active myeloma, where you have a tissue diagnosis, where you know that there is an underlying plasma cell proliferative disorder, done either by bone marrow biopsy or any tissue biopsy. And a patient should have at least one of the SLIM CRAB features. What is the SLIM? SLIM is S is for clonal plasma cell, bone marrow plasma cells. So that should be more than 60%. LI is light chains, where the ratio should be more than 100. If it involves kappa, less than 0.01 if it involves lambda. And MRI should show more than one focal lesion with at least each being at least 5 mm in size. Then the traditional CRAB, where calcium should be more than 11. Renal insufficiency because of any other cause ruled out and assumed to be because of myeloma, where creatinine clearance should be less than 40 or creatinine only should be more than 2 milligram. Anemia, yes, anemia again, other causes ruled out, and we can put it as only due to disease, then anemia and bone lesions. So these are the risks. We can see multiple genetics that we can, genetic factors or genetic mutations that can occur in myeloma. The high risks include 11, 14, 6, 14, 14, 16, 14, and monosomy 13, complex karyotypes, and deletion 17. I think the deletion 17 has gone into standard risk. It should be in the high risk. So this is how they are classified. So 14, 16, and 414, along with the deletion 17, are traditionally considered as very, very high risk markers. Apart from that, deletion 17, any malignancy, as we know, can be a problematic, can be a huge problem on that. Next slide, please. And coming to the question of biopsy, there are two issues. One, when light chains are very high, so I can assume it's a cast nephropathy. But even if I wanted to do a biopsy in this case, I would like to know what is the cortex, because there is corticomedullary thinning. Whether there is a corticomedullary thinning, because there is a lot of loss of corticomedullary differentiation, plus patient is hypertensive. So ideally, in this case, I would like to know what is the degree of myeloma involvement, whether it's a CKD which has become problematic by an acute renal dysfunction because of myeloma, or it is only an acute renal dysfunction because of myeloma, in which case it can be completely reversed. So from that point of view, if it's possible, I would like to do a biopsy. But as this paper suggests, this is recommended only patient with high degree of albuminuria to rule out any other plasma cell disorder apart from myeloma class nephropathy. That is to rule out AL amyloidosis or monoclonal immunoglobulin deposition. And if the patient has a free light chain level less than 500, but still has a nephropathy, then yes, they definitely know. Because when there's a high light chain load, we obviously assume that the patient will have a myeloma class nephropathy. But when a diagnosis is straightforward, no other comorbidity, no diabetes, no hypertension, I can skip the renal biopsy. And this is the RISS staging for multiple myeloma. Stage 1 is when everything is good, albumin is less than 3.5, beta 2 microglobulin is less than 3.5. There are no high-risk cytogenetics and normal LDH. High-risk cytogenetics in this classification includes 414, 1416, and deletion 17, and elevated LDH. So if both of them are not there, it goes into stage 1. If either one of them is there, then it goes to stage 3. And in any other combination, straight away goes to stage 2.
Thank you, Dr. Prathmesh. Nicely you have brought out all those things. That was a typological error of that deletion 17 going into standard risk. So now I'll come to Colonel Ashok Mesram. Ashok, if this...
I think, sir, the last question was left to be addressed, whether the patient is transplant eligible.
Yeah, sorry. That you can answer.
And just from the age point of view, sir, I think I would not like to think about transplant upfront. I think 65 till 65 we do, 65 to 70 we take it with a pinch of salt if the patient is tolerated well, there's excellent response, and otherwise physically or clinically is good, then 65 to 70 we can consider. But as a whole, if it's above, say patient is above 70, we try to avoid transplant.
So here, I think this, yes, you are right. Absolutely. Yeah. The patient is not transplant eligible. The most important criteria is age, of course. Then, of course, most likely we have considered this as having a caste nephropathy, and it is very difficult at this age to give them Elflan, even if, under the cover of dialysis. It's very difficult. So thank you very much, Dr. Prathmesh. Coming to Colonel Ashok Mesram, the patient is dialysis dependent, and what kind of therapy and approach, as already Dr. Prathmesh has told that he is a non-transplant eligible patient. What kind of therapy you will recommend? Is Ashok there? I think Ashok is not there. Dr. Prathmesh, can you take on this question? I think Dr. Ashok is not there.
Sir, good evening, sir.
Hi, good evening.
This patient. Yes, sir. I am here, sir.
Okay.
Am I audible, sir?
Yes, I can hear you.
Sir, I am here, sir. Sir, I am. Sir,
hello.
Can you hear me, sir?
Yes. Ashok, I can hear you. Please
sir,
go ahead.
This patient is 73-year-old gentleman with newly diagnosed multiple myeloma. He has got severe anemia, bony lesions, and high-risk cytogenetics like deletion 17p. This patient has got a light chain disease with a lambda light chain of almost 12,500 and normal kidneys on the ultrasound. So in this patient, the primary objective is to determine the appropriate treatment approach on the basis of biological age, frailty status, performance status, and comorbidities. So this patient also in elderly, the frailty should also be considered based on the revised myeloma comorbidity index. As we know that early discontinuation of therapy due to drug toxicity is associated with a shorter survival. So as per IMWG consensus on treatment with multiple myeloma with high-risk cytogenetics, and also European Myeloma Network consensus on practice in older adults, so both conclude that BORTI-based regimes are maybe partly overcome the adverse prognostic effect of a 17p deletion. So based is a BORTI-based triplets along with addition of daratumab, novel agent. So BORTI-based triplets is like a Borti cyclodexa, Borti thaldexa, or Borti melphalan and prednisolone triplets, because among this patient with high risk cytogenetics, PFS and overall survival is tend to be longer in this patient. So this patient, particularly the severe renal impairment, they are at high risk of early death and other complications. And besides that, also presence of a high risk cytogenetics, and that can lead to very poor outcome. So we can go for a body-based therapies. And coming to the therapies like Borti, melphalan, and prednisolone. So this DARA VMP is actually evaluated in a phase 3 Alcyon trial in transplant ineligible patients. So in this trial, they analyzed the combination of a DARA VMP, that is Borti, melphalan, and prednisolone versus VMP for fixed duration cycles of 9 months of induction in both groups. So DARA monotherapy continued as a maintenance in DARA VMP group. So coming to median PFS, so median PFS in DARA VMP group is 36.4 at 42 months and versus 19.3 in a VMP group. So coming to overall response rate, it was a significant higher overall response rate in DARA VMP group was seen. So overall response rate was almost 91% in 40 months of 40 months in a DARA VMP group versus 74% in a VMP group. Though it has got a significant higher overall response, and also VGPR rates and CR rates with the DARA VMP. So coming to minimal residual disease, the minimal residual disease approx 28% in at the end of a 40 months of a follow-up in a DARA VMP group, they achieved the MRD negativity. However, in VMP group, only 7% achieved the MRD negativity, and that is almost fourfold higher rates of MRD negativity in a DARA VMP group. So more important than achieving MRD negativity is the sustained MRD negativity. So let me emphasize that impact of MRD negative is important, but sustained MRD is more important. And that is seen in this with the DARA VMP, even at a 6 months, it is 16% of a sustained MRD and 14% at the 14% at the end of a 12 months. So it has got a significant higher rates of MRD negativity as well as sustained MRD negativity with the DARA VMP.
Thank you, Ashok. You have really nicely brought up. This has been the therapy which has been recommended now because of its good result, and transplant ineligible patient can be given this. Now I'll come to Dr. Hamza. If this patient had normal renal function, that this patient is a most likely caste nephropathy, but it would have been a normal renal function. What would have been your other options of treatment? Dr. Hamza, you are there?
Yes, sir. Am I audible, sir?
Yes, I can hear you.
Yes, thank you for the question, sir. If the patient had a normal renal function, at the outset, I'd say that the patient would be very fortunate, because patients with abnormal renal function and multiple myeloma, they have the very limited drugs available, and they have early mortality, which is much higher. So with a patient with a normal renal function, the two added advantages are, obviously we can use the LEN-based therapy. And second thing is that for patients who have a lot of skeletal lesions, zoledronic acid becomes available, which would otherwise not be available. So for any patient who is transplant ineligible, sir, there are 2 or 3 parameters that we look at, because this is generally going to be consisting of more cycles of therapy. So and the patient would be having more comorbidities. So we require a highly efficacious regimen. The regimen should have less side effects, and the patient should be able to tolerate the regimen. And the third thing is the patient should be able to continue. So in our practice, to decide how to treat transplant ineligible patients, and according to the recent recommendations, the only thing that we actually need to decide is whether the patient can take daratumumab. So if the patient is able to take daratumumab, then daratumumab-based regimens are considered to be the best regimens at present. And if they cannot, then the second option would be a triplet regimen with bortezomib as well as lenalidomide. So DARA-based regimens have been, especially DARA and LEN-based regimens have been evaluated in the Maya trial, which has compared the DARA, LEN and low-dose dexamethasone versus LEN and low-dose dexamethasone. But this one was basically not a fixed duration trial. The daratumumab was continued, Initially, it was continued weekly for the first 2 cycles, then once in 2 weeks for cycle 3 to 6, and then it was continued every month until progressive disease, along with lenalidomide 25 mg and dexamethasone 40 mg, and was compared with this thing, lenalidomide and dexamethasone. So it has shown significant advantage and significant progression-free survival benefit with DARA, Len, and Dex at 4 years as well as at 5 years. At 4 years, the progression-free survival for DARA, Len, Dex was 60% as compared to 38%. And at 5 years, it maintained its progression-free survival benefit 52% versus 28%. Now, the progression-free survival benefit, basically, it reflected the increase in the overall response rates. Can you go to the next slide, sir? So there was an increase in the overall response rates from 93% to 82% as compared to 82%. But the more important thing was that out of the 93%, almost 50 to 60% of them was better than VGPR, as compared to only 30% of them this thing achieving VGPR, CR or stringent CR with the Len-Dex regimen. So therefore, DARA and Len, it leads to this thing deeper and more meaningful responses, which then translate to a progression-free survival. And one of the advantages of this trial was that they checked the MRD negativity rate during this treatment, and there was a threefold increase in MRD negativity rate with 31% as compared to 10% when we used DARA. And the sustained MRD rates were again very high, 20% at 6 months and 16% at 12 months. So therefore, a patient who is eligible and who will continue daratumumab long term, daratumumab, Len, Dex, or daratumumab along with VMP become the first line treatment choices. And for those patients who do not or cannot afford daratumumab, which are the majority patients in our country, we would continue with a triplet regimen along with bortezomib, lenalidomide, or bortezomib and thalidomide.
Thank you, Dr. Hamza. Thank you very much. I think with the availability of daratumumab, now this even transplant ineligible patient, if we can give this monoclonal, it adds to the benefit to the patient and survival. Thank you.
Yes,
so this patient is non-oliguric and creatinine remains high, as we have taken it as a cast nephropathy. He is on dialysis. And as an institutional policy, we have started this patient on DARA VTD, and he is into the therapy for 3 weeks. Thank you very much. Now I'll go to the next case. This case is of June 2021. This is a 53-year-old lady, wife of a retired JCO. They is presented with symptomatic anemia for 1 month and back pain. At the onset, evaluation showed that she was anemic. She had a creatinine of 2.9. And we evaluated for myeloma. He had 40% plasma cells on aspirate, and biopsy was consistent with plasma cell dyscrasia. Immunoelectrophoresis showed a IgG kappa. His FIS as well as karyotype was negative. We didn't get any translocation or any abnormality. And we did a PET. There are multiple spinal lesions, hip and skull lesions were there. Maximum SUV was 4.6. So Dr. Lingaraj is there?
Yes, sir, I'm there. Sir.
Yeah, please. So if you can take on this patient, is there how is the risk factor for this patient? And this patient, I think it's eligible for transplant. And you can tell this more, and what kind of therapeutic approach you would like to have in this patient particularly?
Yeah, thank you, sir, for that question. So coming to the risk factor, now she has renal dysfunction, and that is probably because of cast nephropathy. And in the scan, I can see some pelvic lesions mentioned there. So I think there are two important risk factors: renal dysfunction, and is there any bone lesion which is in the weight-bearing areas? Because my concern will be I can't use any bone-modifying agent because of renal dysfunction. Then I should consider radiation if there is any area which is weight-bearing. And now coming to the eligibility for transplant, now most patients where we start treatment, they do improve, the renal functions do improve eventually, and most of them become eligible for transplant. So if this patient, looking at her age, she should be eligible for transplant after 3 to 4 cycles of induction treatment. Now coming to the induction therapy, as she has a ongoing renal dysfunction, so my treatment options will be VTD or a cyclophosphamide based like VCD regimen. Now coming to use of novel agents, yes, if the patient can afford, then maybe a daratumumab based induction along with VTD can be recommended, at least during the induction phase, as shown by the Cassiopeia study, where the patients who have are newly diagnosed and transplant eligible were randomized into DARA-based induction with VTD versus VTD alone. And with the primary endpoint of CR, stringent CR rate, the study has definitely shown improvement in the response rate and as well as the event-free survival on the long run. Now, coming to use of maintenance, the study did have a second randomization of maintenance DARA versus observation. I think the updated analysis have shown that the patients who didn't receive DARA, their outcome was worse as compared to the patients who received either during induction or maintenance. So some way, if the patient is not receiving LEN-based induction, that is VTD, then probably DARA adds benefit. But for this patient, if the renal function improves, then I would switch to VRD, and maybe DARA can be used in the later line of treatment if that is so. Yes.
Thank you, Dr. Lingaraj. It was nice. So in this patient, sorry. See, this patient, we wanted to do a kidney biopsy, but at that time, in the peak of the pandemic, there was problems for admission, so we didn't do it, and she received VCD. Within 3 weeks of therapy, we gave denosuzumab in place. We didn't give Jometa at the onset. Within 3 weeks, she recovered her renal function. Probably this was not cast nephropathy, and we did later on. We did evaluation on the kidney, and it was all normal. So she achieved a remission after 12 weeks of therapy with DARA VTD, and she underwent a ASCT in December 2021, autologous stem cell transplant, when her renal function was absolutely normal. So now I'll come to, thank you, Dr. Nayak. Now I'll come to Dr. Abhishek. This patient, after autologous stem cell transplant, who has received a DARA-based induction, that is DARA VTD, what is the role of consolidation post-transplant, and will you like to have DARA maintenance in these patients?
Thank you, sir, for the question. So this is a young patient, relatively young patient, treated with daratumumab-based regimen and has undergone transplant. Patient is in complete remission. So the question is to whether we can offer any further anti-myeloma therapy to improve the outcome. So trials wise, I think for many years, constant efforts are going on to improve this post-transplant patients' outcome by offering them additional anti-myeloma therapy. But if we talk of conventional therapy, I think RVD is the regimen which was studied on most number of patients in prospective manner as a consolidation post-transplant, even though it improved response rates, but there was no benefit in PFS and overall survival. So current guidelines with conventional therapy is not recommending consolidation, particularly when patient has received IMiDs or potassium inhibitors in induction. So present guidelines are to give maintenance, preferably single agent lenalidomide, or in high risk patient we can add len plus dex. We do have some issues due to toxicities of this len maintenance and even other issues like second primary malignancies. So definitely there is a scope to get a better maintenance regimen. So can we go back? Yeah. So most of the daratumumab trials in transplant eligible patients, they did include consolidation and maintenance. So Cassiopeia trials part 2 was to evaluate daratumumab maintenance, and patients were randomized again after the consolidation with DARA and VTD. In randomization was DARA versus observation. So there are 4 groups to evaluate that patients with DARA VTD receiving DARA maintenance, patients with DARA VTD undergoing observation, patients without daratumumab as induction consolidation receiving DARA, and patients with VTD induction and just on observation without DARA maintenance. So CR rates are best with patient receiving daratumumab and receiving daratumumab-based regimens in induction and consolidation. And worst findings were with patients who were treated without daratumumab initially and were not given any maintenance. Yes. So can we go to next slide?
Next slide.
Sorry. Sorry. Back. Yes. So interestingly, patients who were treated with daratumumab initially, there was no clear-cut benefit of daratumumab in this trial for a few months. But the major difference was patient receiving daratumumab and patients on observation who did not receive daratumumab in initial treatment. So treatment interactions were significant. Next slide, sir. Yeah, this is covered.
Okay.
Sorry, sir, back.
Okay.
And the most poor outcomes were seen for patients who did not undergo randomization. And the common reasons to not undergo randomizations were treatment-related adverse events, disease progression, and response less than partial post-consolidation. So essentially, these patients have poor biology or major adverse events, and they could not receive any further treatment. So learning point from all the daratumumab trials is that when we add daratumumab to our baseline regimens, it definitely gives deeper remission, and with time this response actually improves if we continue daratumumab. So our patient, I think I definitely would like to continue daratumumab maintenance. For consultation, I'm not very sure, but maintenance I would like to give.
So this patient was started on consolidation. I agree to you to certain extent, and we planned, we gave 12 weeks of consolidation, and then we did a marrow, which was MRD negative. He is been on maintenance now. We are not giving daratumumab in the maintenance. He is receiving only lenalidomide maintenance because he is MRD negativity. So our strategy in that newly diagnosed multiple myeloma, those are standard risk or intermediate risks, and they are transplant eligible. So give them the best whatever is possible. And just this patient has just been started maintenance. Maybe we'll consider if there is any disease comes back in this patient to give daratumumab. So now I'll come to the.
We are falling short of time.
Sir, I'll quickly go, sir. I know, sir, this half an hour for so many.
Thank you so much.
So the third case is a 57-year-old retired soldier who presented with symptomatic anemia, was diagnosed as myeloma, and in the most important thing was he presented with hemolytic patches, and there are 2% plasma cells in the peripheral blood and 20,000 platelet at the onset of the diagnosis. So he was diagnosed as a IgA lambda disease, and he had mildly delayed renal function, and PET showed multiple lesions. His again his FIS showed 1Q gain, which was actually a bad risk. So this patient, I'll just come to Dr. Nidhi now. He's left, and one more panelist. Do you want what is the risk in this patient, and what therapy you would like to start? Dr. Nidhi, if you can quickly give, as sir told, already time is short.
Yeah. So definitely, sir, this is a high risk patient because of two reasons. One, there is a circulating plasma cells in the peripheral blood, and platelet counts are also low. So I would actually like to see whether this patient is going towards a plasma cell leukemia. Just to make a point over here that the previous definition of plasma cell leukemia wanted 20% plasma cells in the peripheral blood, but recently the IMWG has released a consensus recommendation where they suggest that even 5% or more plasma cells in the periphery makes it a plasma cell leukemia. And even if the patient is having 1 to 2% plasma cells in the circulation, it makes the patient a high risk, and they can transform into PCL very quickly. So 1Q gain as well as this circulating plasma cells makes it a high risk. Also, I would like to rule out DIC in this patient because the platelet counts are really low. So these are the two things which I would like to point out. And considering it to the that it is a high risk disease, I would like to give the most effective therapy upfront, because otherwise the patient is not going to give us time. Definitely a triplet. I would prefer VRD. Is the preferred regimen with or without addition of daratumumab in this particular patient. We do not have a head-to-head.
At that time, we tried to give dara to him, and that time we couldn't procure. It was individual patient based, so we could not give him daratumumab, though we wanted. But at that time, on the upfront also, dara was not approved, so we gave. You can go ahead next time.
Sure, sir. So then in that case, if suppose there's a difficulty due to any reason to give daratumumab to this patient, then I would prefer VRD. VTD can also be used, but considering there is a integrated analysis of VRD versus VTD, as far as the GEMS and the IFM studies are concerned, and it has been shown that VRD is better in terms of achieving more VGPR rate. So both of the regimens are okay, but as far as the SWOG trial is there, which has already shown our overall survival benefit of VRD versus the doublet, and so we prefer VRD regimen.
Okay, thank you. Actually, because of that initial 1.8 creatinine, we gave him induction with VTD. Then after 12 weeks, creatinine became normal. We changed it to VRD. And he achieved a BGPR after 12 weeks and a stringent CR after 24 weeks. That is on completion of both the regimes. He underwent a autologous stem cell transplant, and post-transplant consolidation he received as botensilimab and lenalidomide. And after 12 weeks, he was MRD negative. We started him on R maintenance. 6 months on maintenance, he was asymptomatic, but his monitoring showed that there is an increase of lambda chain. And gradually it increased 1.2 grams. And after 6 months, we did a bone marrow and it was seen that 10% plasma cell. Patient still asymptomatic. Dr. Nisad, my last panelist, will this patient require treatment? And what should be the approach now?
Yeah, definitely this patient requires treatment as it's a progressive disease now, and where we can see that the plasma, the M band has increased from 0.3 to 1.2. There is an absolute increase of M band by 0.9 grams per deciliter. So this patient has a progressive disease now and definitely requires treatment. The second question is about what would be my approach. Now I would like to reevaluate the disease burden completely in this case, where I would like to see whether there is a clinical relapse per se. I would like to do a PET CT and a bone marrow to see the number of plasma cells.
Bone marrow was done. Bone marrow was done. It was 10% plasma cells.
Yeah. So a fish or a cytogenetic evaluation should again be considered because the patients might have a different cytogenetics now. After the complete evaluation of disease, then we would like to go for the treatment point of view. So my approach here would be to see, there are various factors when we treat the patient considering the first relapse. So there could be treatment related factors where we definitely see what therapy the patient has received previously. The second is, whether the patient's disease is, whether the patient has relapsed on len maintenance or bortezomib maintenance or a dual maintenance, to see whether the patient is len refractory, bortezomib refractory or dual refractory, which decides our treatment now. There are various host related factors where comorbidities are important. The patient's performance status is important, and the cytogenetics is important. And then we have, the treatment, the tumor related factors, where it is important to see whether the patient has a plasma cell leukemia. And as we have discussed, that the definition has been revised, where more than 5% plasma cells are, considered as plasma cell leukemia. Again, if the patient has extramedullary disease,
now the patient has relapsed and has got 10% plasma cells in the bone marrow, and patient is absolutely asymptomatic otherwise. That is what my patient is. So thank you very much. As we have got short of time, the patient has just been started on DARA KD as a fast relapse. So sir, I'll just take 1 minute, and if I show you that ESMO guidelines of 2021 and whether they are eligible or non-eligible for autologous transplant, a monoclonal plus double or triple agent therapy is most suited, and it gives a long-term survival. So coming to daratumumab, this agent has been used in relapsed refractory as well as in a newly diagnosed multiple myeloma with various combinations with excellent results. Sir, I'll thank you very much, sir, and I thank all my panelists for giving excellent, deliberation on their question. Any questions, sir, if I or my panelists can take on, sir?
There is one question lying in the question box, which is related to, if a patient does extremely well on these new agents, can we skip auto transplant?
sir, if I ask my view, sir, I like extremely well, sir. We all do auto transplant when the patient is doing extremely well and they are disease free mostly, whether they are VGPR, PR, or even stringent CR, sir. So if a patient is well, doing well, giving a consolidation and taking into the depth of response is most welcome, we should give. But yes, if patient has got own reservation, if there are some problems for taking up the patient for autologous transplant, yes. And age becomes the most of the time, age becomes the biggest factor, and we are not able to do the transplant. Otherwise, if a eligible patient has a big consolidation, he should undergo a transplant.
Thank you. Perfect reply. So thank you, Brigadier Dr. Satyaranjan Das, and the panelists, Dr. Prathamesh, Dr. Ashok, Dr. Hamza, Dr. Nidhi, Dr. Lingaraj, Dr. Abhishek, Dr. Nishad, and others for a wonderful discussion, very, very educative and very timely. Also thank Jensen, especially Dr. Dhara Sanghavi, Mr. Mr. Hitesh Khandelwal, Mr. Dhumal, and Mr. Kanan for supporting our academic activities. Late in the evening, time for dinner. Enjoy dinner with your family, and once again, grateful to all of you for being with us this evening for the MHG program. Bye-bye.
Thank you very much,
Thank
sir.
you,
Thank
sir.
you very much, sir. Thank you.
Bye-bye. Bye-bye.
Bye.